Okay, friends, we are live and I have with me my boss, my teacher, Dr. Aswath Kumar, a renowned gynec cancer surgeon in India and especially in Thrissur in Kerala. Aswath sir, hi, welcome. I am very
Hi,
nervous
Jay.
because
Hi.
I am going
Very
to be
nice to see
operating
you.
live in front of you.
Oh, very proud of you because as a teacher, I am so proud that a student viewing a student operating so well.
Yes, sir. This is cancer endometrium. As I told
Sir,
you.
so Jay, what is the usual step? You separated the sigmoid colon and going ahead.
First step is always separating the sigmoid colon. I will expose the ureter the first, always. As soon as
We
ureter is
can
exposed.
nicely see the ureter going down.
Yes, sir. And I will try to go and coagulate the IP ligament as high as I can, you know.
Okay.
Because second step after this is going to be, as soon as this sample goes for frozen section, the second step is going to be that I will be doing pelvic lymphadenectomy also.
Okay.
Yeah. There is no pelvic lymph nodes. There is nothing in the lymph nodes. But since
you had done a pre-op MRI? Pre-op MRI?
Yes, sir. Pre-op MRI has been done. Pre-op biopsy has been done. It is a low-grade endometrioid adenocarcinoma, sir.
Low-grade endometrioid adenocarcinoma. Okay. So it's a routine that you send for frozen, the specimen?
Definitely, sir. We'll try to send for frozen because in frozen, if in case we come to know some more information, no, in the site of frozen, then we may be able to plan our surgery slightly better for the patient, you know.
Okay.
But it is not a mandatory thing to do, sir. Not compulsory to do it.
It's not nowadays. With the help of MRI, most of the things can be detected. So it's not mandatory nowadays frozen in endometrium.
Correct. It is not mandatory, sir. But
otherwise, you are doing sentinel lymph node, it's okay.
Sir, sentinel lymph nodes we have started to do. And the only important thing about sentinel lymph nodes is that apart from us, we require somebody who is very good in oncopathology.
Very good pathologist. That is what we have. You should have an oncopathologist because otherwise, so basically you can do the basic staining and see the lymph nodes are positive or not. If the lymph nodes are positive, definitely you have to go for lymphadenectomy. That is the basic.
Correct. So, sir, one side.
But otherwise, it requires ultra staging.
Yeah. Sir, what is your experience?
So you are going
sentinel?
And we are doing it regularly. So once we do regularly, the frozen session doesn't have much value. That is what happens. So frozen, you can do frozen only if the large lymph node and the H&E stain, hematocele eosinophil stain is done and it is positive, that is positive. Okay. Other micromets and all these things cannot be detected in frozen. Okay. With your experience, you can do sentinel because nowadays even the lymph node dissection is needed or not many times is a big question. So we can do sentinel, send it for histopathology. Only sentinel you can do. If the sentinel becomes positive, patient requires chemoradiation. That is the only other way of dealing with it. Okay, Jay. So if you have an enlarged node, you do a H&E stain pathologist and says positive, you have to do the full lymphadenectomy. The sentinel node which you have got, you can send for, but there also the problem is that you cannot get the micro metastasis or micro staging. Then you need a real oncopathologist. That takes time also. Okay. So how much value it has? It's a controversial thing also. Okay.
Yeah. I agree, sir. I completely agree to that part that, you know, and sir,
according to me, this is a
it's a previous cesarean, sir.
According
previous
to you?
2 cesareans.
That is why. Previous cesarean, you can tell that what are the ways which you identify the bladder, or you just go by the plain touch. You are magical.
I am actually now only going by the touch only, sir. Here.
That is what you are a real expert. Every day when you are doing 10 cases, then touch is more than enough. All your instruments has now touch sensation.
Correct. So there, see, the bladder has gone down completely, sir.
Very good, very good, very nicely. Without even a drop of bleeding is not there at the bladder side. Now we are going to the other side.
Aswath sir, one question I wanted to ask you from my perspective. In all cases of cancer endometrium, which we are trying to deal with, sir, many times people are still wondering and having that doubt that shall we do hysteroscopy or no hysteroscopy before for taking biopsy. Just wanted your opinion, sir.
No, see, no need actually. See, endometrium, once it is diagnosed by even our office people, is more than enough actually. So you get a very good result with people itself. Okay. So once you get people, if you have an office hysteroscopy, well and good, you can do it office. But most of the places in India, they don't have that office procedure. Office setup is not there. You should have, and many patients are reluctant. You should have a very good patient compliance to do a office hysteroscopy. So most of the time then require GA, anesthetist, and that's a big headache for them. So for a normal gynecologist, people is more than enough to diagnose a CA endometrium. In doubt, whenever you are in doubt, endometrial thickness is, and the people is not giving you result, and you suspect, then you do a office hysteroscopy, and if any localized lesion is there, you take biopsy and send it. Otherwise, no need, Jay.
Okay. And sir, in this, once we are like many times, I have seen you doing so many lymphadenectomies consistently. Okay, people who are worried that lymphadenectomy is very morbid and all these types of things, I have seen that, sir, when you are doing lymphadenectomies or the technique in which you have taught us to do lymphadenectomies, we never saw any morbidities in post graduation.
Nowadays with the technique, one thing, the laparoscopy. So we never had lymph cyst or edema or so the basic thing is that the laparoscopy, the planes, the hemostasis, everything is very good. And be in the don't do unnecessary things. Be in the correct plane. Be in the boundaries of lymph nodes. Adequate lymph nodes are removed, more than enough. So in case where needed, only go for para-aortic in CA endometrium. Very early stage, no need to go for para-aortic lymph node dissection. So it's always a controversy. So when it is involving, okay, you can do a para-aortic lymph node. And if you are suspected, enlarged para-aortic lymph nodes are there in MRI. Otherwise, doing para-aortic in an inexperienced hand, then you will end up in complications. Otherwise, the chance of complications is very less actually.
Correct.
So I am not much seeing lymph cyst or lymphedema and all these things in case of CA endometrium lymph node, pelvic lymph node dissection.
Yeah, that is what I wanted to tell to people, that normally what people are worried about, the lymphocyst and all, it is not that common, and it is
not that common. That many people don't know. They read books and say that okay,
they only read books and they get confused. So, there is it's very uncommon.
Lymphadenectomy, even bleeding during lymph node tendectomy is very less unless you injure a major vessel. And even if there is oozing, keep a mop there or a gauze there. And go to the other side. While you come back, it will not be bleeding. So that oozing and all, no need to go and coagulate or anything.
Aswath sir, one more question. See, I am currently using a technique where I am not even touching the uterus at all. No touch technique. But people use myoma screw. Correct? So, does it make any difference?
In endometrial malignancy, your technique, even I am following your technique in my endometrial malignancy. Never do I catch only the round ligament. If you like, I never hold the histosa anything. Round ligament is my. I pull the round ligament to other side. My assistant holds the round ligament and pulls the uterus by both sides. That's it. That is what it is done. Never do put a manipulator from below or a myoma screw from above in a case of endometrial malignancy. So, and endometrial malignancy, another thing is that uterus is very soft. And your myoma screw is not, it will not hold the uterus also. So you have to be very careful. That's it.
Yeah, that's an important take-home point. for all students that it is not compulsory to use myoma screw if you are a laparoscopic surgeon operating on CA endometrium.
It should not be used, Jay. Not compulsory. In endometrial malignancy, myoma screw should not be used. Manipulator should not be used. That's it.
Yeah, should not be used.
Because you injure the serosa and all the material. If it was an early stage also, everything comes out through the serosa and all, then you are disturbing the whole disease actually.
Yeah, true.
And and the staging, when you send the specimen for staging, the pathologists also get confused. What is this? All the material comes out through the serosa, out and all this thing. Then they will upstage the disease, you will have problem.
That is a problem. If they upstage the disease because our specimen has not been submitted to them correctly, then there will be a problem for the patient, you know.
Problem, the big difference. See, your case doesn't require any adjuvant treatment. The present case, what you are doing. So you manipulate it, open it, and whatever, disturb the whole uterus. Then the pathologist doesn't know. Otherwise, you should inform the pathologist clearly that you have opened and all this thing. Otherwise, they will give you a next stage, which has involved serosa and all. They will give more than half thickness. Then the patient definitely has to undergo at least vault brachytherapy.
Correct. And then vault brachytherapy is very irritating for patients, you know. So friends,
nicely, here, all of
we are about to finish the
uterosacral.
About to finish the hysterectomy.
So Jay is about to finish the hysterectomy. Hardly has taken 10 minutes. He is finishing the hysterectomy. In a previous cesarean case, you should understand. So, Scherer, you are seeing the instrument used by Dr. Jay Scherer. Most of you are you would have seen Jay's surgery before also. So what he is using is a Scherer. So there is a small bleeder on the right side.
It's a uterine artery which was bleeding. See that? So I'll just coagulate it.
That is why sometimes Scherer cuts fast. So the coagulation part may not be sometimes.
Correct.
When you are doing fast, you have to be, as a beginner, everybody should use bipolar in one hand and Scherer in the other hand.
That is a very important point, sir. That is correct.
So when you reach the uterine, you use bipolar. So you can use the bipolar to messenger bipolar use. All of you can use messenger bipolar, and Scherer is the best combination. So the messenger bipolar will act as a grasper as well as coagulation. So whenever you feel
now
that
you have also reduced using harmonic or what?
Reduced using because see, Scherer cost effective. That is the reason, and it is very fast actually. But harmonic is a very good instrument. We cannot say very good instrument. Harmonic is a very good instrument. Those who can afford harmonic, and it is a very good instrument, no doubt.
Okay.
But harmonic will never coagulation, and uterine you have to use a bipolar. With harmonic, you should have skill to coagulate the uterine. You can coagulate the uterine with harmonic also, but better to use a at least as a beginner, till you are well versed in harmonic, at least use a bipolar to coagulate. Okay.
Right. So, sir, I'm opening up the vault now actually. And I will try to remove the entire specimen intact from the vault.
And you will be doing lymph node directly or after getting the
no, directly, sir, because myometrium is more than 50%, no?
Then there is no, see, actually in all cases of endometrial malignancy, my view is better to do lymphadenectomy or at least a sentinel lymph node. So even if you get a very, so lymphadenectomy is a must. You should not believe in telling that it is 1A, so well differentiated, grade 1 and all these things, no need to do. But many times when the pathology report finally comes, then you will be in a trouble. Your surgery will be incomplete.
Correct. So I think it is better to do any which way, sir. In this case, when myometrium is more than 50% at a focal point, I think pelvic lymphadenectomy should be done, you know.
Lymphadenectomy should be done. Better to do lymphadenectomy.
Correct. So here I am. Hysterectomy has finished, guys. I will just take the specimen out immediately, and And once the
One
specimen
difference,
comes
Jay,
out,
what I do is that I do the lymphadenectomy initially because I do the sentinel lymph node. So when I remove the sentinel lymph node, along with the sentinel lymph node, I finish the lymphadenectomy also. So your style is different. That is okay. Then I put that lymph nodes in a endo bag and a glove bag and keep it there. And at the end, I take along with the uterus. So that is what I do. So many surgeons do different way. Jay, the advantage of Jay's technique is that you get lot of space in the pelvis, so you can peacefully do the lymphadenectomy.
करेक्ट. एक सेकंड गैस ऑफ करो, मुझे सैंपल निकालना है. गैस ऑफ करो, एक सेकंड ऊपर से. नाइस दे दो. 11 नंबर चलेगा. यहाँ पे पकड़ो, ऊपर पकड़ो. So the sample is about to come out, guys, in just 1 minute. ये निकाल लो. It's a very bulky uterus for her vagina.
Jay, that is the reason why it is taking some time to come. Okay.
Correct. It is done. It is out.
It is done.
Right. Intra-abdominal picture, please. Aswath sir, I think, you know, a lot of students are watching and they will be watching this. I think what they probably should learn is one of the things which you had taught us when we were PGs. You know, you used to draw that diagram of paravesical space and pararectal space. And it used to be a very nice, lovely diagram, you know, demonstrating where the artery is going, where the vein is going and all these things. And I think many a times, if one remembers that diagram, then life becomes very, very easy when it comes to operating this type of cases, you know.
That's what anatomy is the most important. Anatomy, once you know, you are thorough with the anatomy. That is what always I say, predictive anatomy. What structure is below, what structure is going to come. If you know, then they see how well J is going into denalvillus fascia. See, 2B is going between the two layers of denalvillus fascia. Like this, he can go up to the perineum. So in this case, not needed. So when you fix the mesh and all, we will go down. Maximum, we will go up to perineum and then fix the mesh. So here he has done now. Now you should start the lymph node dissection from the apex. So the
I will start
apex
it from
part
the right
means
side.
it's a bifurcation of the external and internal common iliac artery, but divides into external and internal iliac artery.
Right. Sir, any specific tips and tricks which, you know, I have always remembered, which you have taught, you know, very long back when, which you had taught very long back when, you know, when we were PGs, and that trick was very nice. And the trick was always that, you know, everything should come out in a single block of tissue.
Single. So for that, you start from the lateralmost part of it, medial to ilioinguinal ligament at the junction of the, and take all the lymphatic tissue. You don't have to palpate and see this node is big or this node is, take all the lymphatic tissue over the vessels.
Just
and
showing
bear of the vessels.
See that?
This is the bifurcation. Now, from there you start, then go laterally, take all the lymph nodes from the medial to genitofemoral nerve or ilioinguinal nerve over the psoas muscle. So from there you take.
Correct.
Say very nicely, you are seeing all those who are, it's a visual treat for everybody. So you are seeing the vessels, you are seeing the, you can see. So this is the psoas muscle below, and nerve also you can see. So you.
Sir, can we compromise the nerve? Is it okay?
It's okay. Even if, but try not to injure. See, see, in pelvis, except for external iliac artery, you can cut any vessel. Except for external iliac artery. External iliac artery, if you cut, you have to immediately suture it. Otherwise, limb will be gangrenous. Even the external iliac vein, even if you tie, you can manage it later. But all the other things, All the other things you compromise also this way, nerve, whatever it is, the patient will not die. The life of the patient can be saved. So that keep in your mind. You don't have to worry at all in pelvis. Okay. Be brave to do whatever. See how Jay is doing. Is going over the whole external iliac till the circumflex iliac vein he will reach. So once you reach the vein now, now the circumflex iliac vein will be crossing. It will come. There is you have to stop there. That is sometimes we call it as corona mortis, because this circumflex iliac vein and the external iliac vein, it gets connected down actually with the external and internal iliac vein connection. So if you injure to get a bleed, you may get, even then you pack for 10-15 minutes, it will stop bleeding. Even then I am telling you. So you don't have to worry that also. See, even if say corona mortis, all big words you will see, but you will be able to.
Actually, corona mortis is something, if you injure, you can simply coagulate. It is so easy.
That's it. It's nothing great, but only thing you have to be, the field will become messy. That is the only thing. Nothing else. You will be able to manage the whole thing.
Correct. See that genitofemoral we have protected, Aswath sir, actually.
Yes, we have there. Genitofemoral is there. You can see the genitofemoral, and now you can see the circumference iliac vein also there.
Underneath, yeah.
Underneath,
sir, tell me,
this is the circumflex
one
iliac vein.
This is a message which I want you to give to all juniors, me and all other juniors. How do you develop confidence to continuously operate bad cases in the pelvis?
And in normal cases, actually it should not be an advice to people, because people say that in normal cases, in normal cases itself, Jay, you have to do little dissection. Start doing dissection. Open up the spaces. Don't coagulate or do anything. Open up the spaces slowly and keep it and see the anatomy. So slowly, it's only learning takes time. So it's so nicely you can see Jay has gone till the circumflex iliac vein. Now he is coming back, bearing of the external iliac artery, going down. Now below that external iliac artery, you will see the external iliac vein. So that blue color vein you are seeing, pair of that vein also, all the lymphatic tissue over the vein.
Yeah, this full lymphatics will
remove. You go down, lift the external iliac vein. Lifting the external iliac vein, you will reach the obturator fossa.
Correct.
So once you lateralize the external iliac vein, easily you will reach the obturator nerve. Don't go below the obturator nerve, then there is bleeding. So reaching the obturator nerve, you pull the whole lymphatics. So the whole lymphatics below also will come with up like this. So don't dissect down, but because sometimes obturator vessel you injury, there is bleeding which is little difficult to control. So that also you can coagulate. There is no problem. That also you can coagulate, but we have to be careful.
That corona
then
mortis
we are very confident that.
See, corona mortis here. See, that's the connection. So that is what Aswath sir was mentioning, you know.
Connection between the external iliac vein and the internal iliac vein. Almost it's a connection.
Correct.
So that is what is called the corona mortis. Yeah. So even this external iliac vein is important when you do pectopexy. While another surgery where you injure the external iliac vein is the external iliac, not external iliac vein. The circumflex iliac vein is while doing pectopexy, because the circumflex iliac vein lies over the pectineal ligament.
Right. Sir, how do people manage that injury then?
Just coagulate it, nothing else. So even if we say that it's corona mortis and all, but when don't worry about the name. You will be able to. And the best thing in pelvis lymph node dissection is you have dissected the internal iliac artery. Any time you can come and ligate it. Or coagulate it or clip it. Any bleeding which is uncontrollable, go and most of the vessels arises from the internal iliac artery.
So many times people say that dissection of the lymph nodes in the fork here. This is important.
The fork, because many times, Jay, at the fork, it will be sticky there. See, when it is an advanced disease, the fork area is where it get infiltrated. So if you try to, without dissecting, if you try to pull that large lymph node, it can tear the external iliac vein, that junction. So therein it is a dangerous thing. So whenever you have a very large node, patiently, it may take, sometimes take half an hour to dissect that node, single node, because it will be into the wall of the serosa or the wall of the vessel actually. So we have to be very careful in that area. That's it.
Okay. But here you can
so
see
you can see the
obturator
internal
nerve.
iliac artery going as the obturator umbilical artery. You see. Now you have seen the. So you have gone into the obturator fossa now. Okay.
Yeah. Everything is released, sir, there. See that the obturator nerve is lying empty.
Obturator nerve, very nicely you are seeing everybody. Obturator nerve we are seeing. So one message is that, what is Jay doing? Jay is holding the obliterated umbilical artery and pulling medially. So that is how it is done. Jay, show the obliterated umbilical artery for them. That is a continuation of internal iliac artery. So that,
this one, sir.
That is the obliterated umbilical artery. Pull it medially. That is the best. Ask your assistant to pull it medially. You will see every structure clearly. So once it's my technique, Jay will be having his own method. I just pull the obliterator umbilical, ask the assistant to pull the obliterator umbilical artery medially. So I can see the whole structures below. And then you can usually, Jay is not at all using any coagulation. You can see here. He's just pulling. Nothing will happen.
Little bleeders will come. That is easy to manage.
That will stop. For the beginner, what they have to do is that once you do one side, put a large gauze there. Go to the other side, come back, nothing will be there.
Correct. They have to only
you
take
don't
out the
believe
gauze
in this
piece.
gauze and all. You will not be believing this gauze and all. That is all for beginners actually. At your level, you don't need anything.
Done. See, one side done, full done. Large, lymphatic exposed. This you have to go for histopathology, and based on on frozen histopathology for the lymphatics, let the reporting come. As Aswath sir has mentioned, if any lymph node is involved, basically even after you do lymphadenectomy, if lymph node is involved, then the patient is going to require compulsorily to go ahead with chemoradiation for sure. This is right side done. Left side quickly, guys. Aswath sir, you have time for left side?
No, I will be watching for the case. So thank you, Jay. It was so nice. And all the students have benefited now. Excellent. We are having, so anybody around the world can be, this is an innovation that will be useful for all the students. Congrats once again for being a teacher and teacher for many generations. Okay. So you know, the people that double the age or people who are the senior most may be watching your surgery and learning. So we all learn from you. Even as your teacher, I am so proud of your achievements. So thank you, Jay. Thank you for inviting me today. I will be there whenever you want. I will come and give you commentary for your surgeries.
Thank you, Aswath,
students, you enjoy the surgery and learn from Jay. Okay, Jay.
Thank you, sir.
Okay.
Thank you.
Bye-bye.
Bye-bye, sir. Okay, continue. So, Aswath sir has left for his surgery. Thank you, Aswath sir, for really joining in. It was so fast on such a short notice. I will also finish off the lymphadenectomy on the opposite side. And so, that will give you a beautiful, crystal clear, complete surgical demonstration for this entire procedure. We had some wonderful wise inputs. I want the mic to go to Dr. Saurabh Metalia, our anesthetist. Does he have the mic? Saurabh sir, normally these types of patients are very obese patients, like how they are on the heavier side of weight, all the patients. So of course, pressure ventilation, volume ventilation, both the things are going to become pretty important for everybody. in a situation like this, no? So I probably really want to know your thoughts, because I know that you are extremely meticulous, like all of us, when it comes to pre-surgical planning and pre-surgical execution for fitness, because you giving a good fitness means the patient goes home on time. And when the patient goes home on time, it means that everybody feels that, the entire team and everything has gone off so nicely that the patient is being discharged on time. So that is the actual importance of all of that, jokes apart. But then I would want you to voice your opinion as to any specific things which we may do for seeking fitness for all of these situations. Right.
Good afternoon.
Mike, sir, my camera. Get Dr. Saurabh in front of the camera, please. His hotness has to be seen.
Okay, so I think I'm audible. Usually, all these CA patients, they are old age, more than 60. So, pre-op fitness, workup, all investigations, 2D echo. Like this patient, we have done everything.
Yeah.
She's a known case of hypertension and diabetes. So, all she's on regular medications. Rejection fraction is normal, and luckily, she is not that obese. It's on a heavier side, but not obese.
Correct.
So we are routine ventilation. We are using volume control, just maintaining normal. It doesn't bleed there on your side.
Yeah.
And that's it. So all basically all patients who come here or anywhere, for example, thorough pre-op investigations is.
Sir, one question I had.
Yeah.
Sorry to
Yeah,
interrupt
yeah,
you.
yeah.
Sir, such type of lymph nodes where we are removing, no?
Hmm.
I have also seen you are, sorry, I'm asking straight post-op because it was
Correct.
in my mind. You are also many times, I've seen you advising for the patients to have stocking.
Yeah.
Post-ops,
Yes.
And patients talking, usually you are taking out very fast also.
We mobilize the patient first.
Correct.
So stocking is basically to prevent any edema.
Okay.
And since our patients usually go home, like maybe next day, probably.
Yeah.
So it is not much of a problem.
Okay.
So your this lymph node dissection and all is okay. Otherwise, many patients have edema.
Yes. I agree, sir.
Yes.
So the stockings is basically for edema.
Edema and to prevent DVT, of course it is. But since our mobility and all is very fast,
Yeah.
Yeah, so basically DVT stockings, they are called DVT stockings because it is used for prevention of DVT.
Right.
Yes.
That is just something which I wanted you to touch upon. But you can please continue because you are mentioning something about the fitness. So.
Yeah, so this patient is fit. She is ASA grade 2.
Okay.
And all investigations are normal. Her creat is normal. Her ECG is normal. 2D echo is normal. So there's no problem. Like, of course, suppose if this patient had some cardiac issues or low EF or something, then we need to, review her drugs, change a few medications. If she's on antiplatelets, we have to stop it for at least 3 days. Cosprin, ideally, if you don't stop, is okay.
Okay.
Clopidogrel, you have to stop for 5 days.
5 days.
Yes, and there are few anticoagulants. Post PTCA, there are many drugs. Yeah, that ideally 5 days.
5 days. Yes. Many times our cardiologists who gives fitness, they also tell the same thing that
Yes.
As soon as surgery is over, after 13-14 hours of surgery,
yes,
you can restart all of this.
Yes, because it's a aspect of stent restenosis. So to prevent that, we need to restart as soon as possible.
Correct.
All IHD patients.
We operated quite a lot of these types of patients.
Yeah, we have seen many old age ladies post PTCA.
Yeah,
they do well. So we basically stick to the protocols.
True.
So that is it.
Thank you, Saurabh sir.
Thank you.
Just gentle, very gentle. Separate. So as Ashwath sir beautifully mentioned, when you have a situation here, you have a problem situation here in this anatomy, all you have to do, okay, is do a good, see that, just do it nicely. Enough. I think I'm done. There is nothing there. See that? Just, I will of course remove all the lymphatics. That is so absolutely sure. There you go. Here it is removed. Everything is done. And we come to an end. So guys, thank you so much. Really for watching. As you watch this during the day, during the course of the day, and I think it really makes a difference when we probably try to operate patients in units like ours, where almost all facility is available for every patient in house, and it really makes a big difference. So guys, thank you for watching. Bye bye, take care, and